Hello and welcome to rePRO Film Festival by mama.film. I am Debbie Samples.
I'm Leila Meadow-Connor.
And I'm Mallory Martin.
As the founders of rePRO, we want to thank the village of people who have made this festival possible, our filmmakers, special guests, partners, sponsors, and of course, our audience. You have lent your time, talents, and expertise to help amplify the voices that are so crucial in the fight for reproductive justice and bodily autonomy.
When you purchase tickets and donate to rePRO, you've become an active participant of change, as all net ticket sales and accompanying donations support our 5 beneficiary organizations.
We thank you for participating in these vitally important call to action conversations and hope you leave feeling empowered to be your own advocate in the world. Please keep women's reproductive rights at the forefront of your mind as we enter this critical election season.
We're pleased to present the Endometriosis 101 Call to Action Conversation, moderated by Jordan Davidson, health journalist and co-founder of Endo Warriors.
Hello, everyone, and welcome to rePRO Film Festival's Endometriosis 101 Call to Action Conversation. Today, we'll be talking about the need for accurate endometriosis information, both inside and outside of the medical community. My name is Jordan Davidson. I'm a health journalist and co-founder of Endo Warriors, as well as the moderator for tonight's conversation. I'm joined now by our incredible panelists, Shannon Cohn, the director of the feature documentary Endo-What, as well as the co-founder of the nonprofit organization Endo-What, Jenneh Rishe, registered nurse and founder of the Endo Coalition, and Dr. Iris Orbuch, endometriosis specialist and the director of the Advanced Gynecologic Laparoscopy Center in Los Angeles. To those of you watching and listening in, feel free to ask questions along the way using the Q&A portal. We'll do our best to answer as many questions as we can by the end of the conversation. Okay, let's get started. Our first question: there's a lot of misinformation surrounding endometriosis. What's something you once believed about endometriosis, but now know not to be true? And I'll open that up to all of our panelists, whoever is most eager to go first.
I can start, it's fine. Wow, I mean, I can start at the very beginning and say that what I didn't know is that it affects so many women, girls, and that many of them are told when they're teenagers that all of the symptoms they're experiencing are normal, part of being a woman. It's all in their head. They're overreacting. And I was actually told as a 16-year-old, I was just trying to get attention. And I remember thinking, like, of all of the ways that I know as a 16-year-old girl, like how to get attention, I can guarantee like complaining about this particular issue is not the way that I would go about this. So that's one of the biggest things. It's most of those people who have, complained about issues, pelvic pain, GI symptoms as teenagers that are cyclical, maybe migraines that are, connected to that. All of the things that you learn about in the film are actually due to endometriosis. And that's something that Dr. Orbuch can talk to. I believe, isn't there a statistic that 70% of all chronic pain patients as teenagers end up being diagnosed with endometriosis? Is that right? Oh, Iris, I think you're on mute.
Sorry about that. So it's 70% of teens who have really debilitating periods have endometriosis, and so that notion of it's normal, live with it, it's just, it makes my blood boil when I hear that.
I would say for me, it's the misconception that it lives only in the pelvic cavity, because I'm one of those patients that didn't present initially with pelvic pain. That was almost one of my last symptoms. My first symptom was shortness of breath and right upper quadrant stomach pain. And when I noticed that this was cyclical, I almost got this bizarre, like, there's no way these things could be related reaction from my doctors. And so I think now having an understanding that it's not just limited to period pain, I realized after, speaking with Dr. Orbuch that, I've had signs of this from a digestive perspective pretty much my entire life and just had no idea. Chronic constipation since I can't even tell you how old. I just thought that was normal for me. And I realize now that that wasn't normal at all.
Yeah. And jumping on that whole idea of gastrointestinal symptoms as a child or as a young teenager, that's for me as a gynecologist, something that I was never taught in residency. Really just started to understand when I was a fellow in minimally invasive surgery, really focusing on endometriosis, but constipation, bloating, diarrhea, like those IBS kind of diagnoses are how endo presents in so many patients. So young girl with doubled over with stomach pain, I have a stomach ache, I'm constipated. To me, I hear that every single day in my office with every patient who walks in my door. Don't get me wrong, not everyone has GI symptoms. Some have just painful periods, not just, because that alone is difficult, but some just have urological issues, some have infertility issues. So if you don't have GI issues, it doesn't mean you don't have endo, but so many do.
Mm-hmm. While we're talking about getting a diagnosis, there are a lot of barriers to diagnosis. And the definitive way to diagnose endometriosis is through laparoscopic surgery. And some doctors, not endometriosis specialists, of course, feel that diagnostic surgery is extreme. So if you suspect that you may have endometriosis, whether because your periods are painful, you're having some of those GI symptoms that we just mentioned, or your periods are causing a decrease in life where you can't go to work or school, or you're dealing with infertility, how can you push your doctor to get a diagnosis?
Can I fill this one?
Yeah, you can.
So I think what's so important is not just pushing any doctor to get the diagnosis, because there's so many varied appearances of endometriosis. And when I was a resident and completed 4 years of OBGYN residency, I only recognized 2 appearances of endometriosis. It was only when I went on and did a fellowship in minimally invasive surgery. And I always tell people that in my first week of fellowship, I learned more about endometriosis than I did in my 4 years of OBGYN residency. And in that first week of fellowship, I learned that endo can be blue, it can appear red, it can appear clear, it can be just a bunch of blood vessels coming together, it can be yellow, it can be brown, or it can be the only 2 lesions that I learned in residency, which is powder burn and chocolate cyst. Those are the only 2 appearances I learned as a resident. And what's so important, teenagers have a totally different appearance of endometriosis often. They have clear lesions. And that is not being taught in general OBGYN residency. So you have to be very careful with whom you decide to have a surgery. So I do think that everyone is deserving of a surgery and an evaluation and diagnosis, but in an ideal world, it should be diagnostic and therapeutic at the same time, with someone who's skilled to know what to look for and someone who's skilled to know how to treat it properly. And that surgery is known as excision surgery or excision of endometriosis.
And what are some red flags that you're not getting the endometriosis care that you deserve?
I think one of the best questions to ask your doctor, in a really nice way, because you want to vet your doctor. Listen, if you're going to buy a home, you're not just going to buy it sight unseen. You're going to call an inspector. Are there termites? What's the foundation like? Is there flood damage? The same thing with the physician. I think you should ask them, like, what percentage of your practice is obstetrics versus gynecological? If someone says 50-50, that means they potentially may be up all night doing a delivery before they operate on you at 7 in the morning. I wouldn't want that as my surgeon. So there's really nice ways just to vet them. What is their focus? And then ask them once they answer you, what percentage is GYN versus obstetrical, then what percentage is surgical? And how many endometriosis surgeries do you do a month? And then you can ask them, what's your modality of treatment? Like, when you see a lesion, how do you approach it? Ablation or burning, which we know are ineffective, or excision, which is the gold standard in treating endometriosis from a surgical point of view. So I think if any physician gets offended by a second opinion or gets offended by really nice, gentle, easy questioning, I think right there, you know your answer.
And from the patient perspective, Jenneh and Shannon, what are some red flags for you that you're not getting the endometriosis care that you deserve?
I mean, I think this could be, this can be answered about any disease or condition or illness that anyone goes through, not just limited to endometriosis, but when you feel like you're not being listened to by your doctor or any healthcare practitioner, then I think that's reason to get up and leave and find someone who will listen to you, first of all, and take your symptoms seriously. With a disease like endometriosis that it's not very well known in the general population, and like Dr. Orbuch just said, not really well understood by the medical population. It's a disease that you really have to fight to be heard and taken seriously. And so many women see 8 to 10 doctors over 10 years before they get a diagnosis with this disease. And that's even presenting with normal, like the more traditional symptoms, like pelvic pain or migraines or GI symptoms, things that many women have. And when you add in some of the lesser known symptoms like Jenneh can speak to, wow. I mean, I don't even know the average time to delay to diagnosis for that. Jenneh, maybe you can speak to that with thoracic endo and extrapelvic endometriosis.
Yeah, I think that I got diagnosed fairly quickly with my thoracic endo, one in part because I decompensated so fast, and it went from just having some upper quadrant pain to being a little bit short of breath to barely being able to get around my apartment. And so the team that I was seeing was really invested in helping me figure it out. I was interesting to them at that point, if I can be completely honest. Before that point, I wasn't. And, I was at a major medical center, and I think that my symptoms being so difficult to figure out was intriguing to this team. And I think that's why that they were invested in helping me figure out what was wrong. But I will say that one of the things that I think is a red flag as a patient is a practitioner that's pushing medical management before a surgical diagnosis. I thankfully had a very involved primary care physician that I'm one of those patients that did say yes to medical management before medical diagnosis. I was put on birth control and changed to multiple birth controls with no relief until ultimately my PCP, after a follow-up, saw that I was taking so much ibuprofen to get through the day and was concerned about that, and decided for me that, we don't even know for sure that you have endometriosis. And if we're barking up the wrong tree, we need to know that. And that too helped me push to get a surgical diagnosis. Speaking to Dr. Orbuch's point, it was with the wrong surgeon because I didn't know enough then, and I let anyone do it. But I will say that if anyone is telling you that you should be on birth control or Lupron, specifically for symptom management before you even know you have endometriosis, that's a red flag.
Definitely. And, to talk a little bit about getting care, I want to talk a little bit about accessibility in care, because one of the biggest barriers to care is, of course, the healthcare system itself. We tell all patients to get excision surgery, such a hard thing to say. And yet surgery often costs upwards of $10,000 regardless of whether or not you have insurance. So how can we make endometriosis care more accessible so that it's not only people with money who can get quality care? And I realize that's a very big question, but we can at least start brainstorming here tonight.
How much time do we have?
Wow. That's something I think that all three of us would love to talk about in different aspects of it. Wow. Okay. So, it's a large systemic problem that there's a lot of institutional resistance to with change. It goes to things like for excision surgery, for example, and that's something that I know Dr. Orbuch can provide her perspective on, is because there's not, actually, I think you should talk about this. Yeah, since that's from a surgeon's perspective, why don't you take it?
Sure. I think, first of all, it being an issue of the reproductive organs, it's just deemed not important in my mind, and which is just such a fallacy. And I think because it's this invisible disease, people don't see it, that they don't put attention on it. But when it comes to proper surgery, the problem is honestly the American Medical Association, the American College of OBGYN, and the insurance companies, because there is not a proper code or a separate and distinguishable code for excision of endometriosis versus ablation. So when you do a surgery, whether you're having your appendix out or knee surgery, there's a specific code. It's called a CPT code, a procedural code. And the ACOG and the AMA, the American Medical Association, has not even come out with a code to code for proper reimbursement for excision of endometriosis. So when I do a surgery and I'm doing a complete, really good surgery to change someone's life, like I have one tomorrow, I may be in the OR for 10 hours tomorrow. And if there's one code, it's called 58662. If I'm lucky, maybe I get $200, maybe $600, maybe $1,000 if it's a good insurance. But you have to understand, malpractice, just to be a physician, I've practices mostly in LA and New York. I'm pretty consolidated in LA now. When I was in New York, malpractice, just to be a doctor, meaning in order to operate in my hospitals in Manhattan, I have to carry malpractice insurance. Full-time OBGYN malpractice insurance in Manhattan in the 5 boroughs could be $180,000 a year. So you have to just pay that much money to have the ability to actually operate on someone. I'm not talking about rent, staff, and I give health insurance to all my staff, my biller, all of the paperwork that we have to go through. How many surgeries does one have to do to pay a malpractice of $180,000 if you're making 200 or 600? Let's say 1,000, because that's a round, easy number. You cannot perform that many surgeries to even pay for the malpractice. So that no one wants to do these very difficult surgeries. When I was primarily based in Manhattan, I got so many referrals from Sloan Kettering. The cancer doctors didn't want to do endo because endo is harder than cancer surgery. So there has to be the recognition that it's widespread. There has to be the recognition that it's difficult surgery. And then our own organizations have to recognize that we need a CPT code. And when I tell you, we as physicians, along with patient advocates, like those here today, have been trying to change the coding. And if I tell you how much resistance that there is from the insurance companies, the AMA, the American College of OBGYN, so if there isn't a code for excision by our organizations, then there can't be reimbursement. So what I really recommend is having all these different individual groups splintering doesn't help. We need to come together and do this crazy march when COVID is over, obviously. And we need to band together. We need to get a form letter. We need to write to every congressman, congresswoman, congressperson out there. We need to put facts on a piece of paper. You can see how heated I get. I'm so mad at this because it is so wrong. Because the insurance companies end up spending more money because there's a 10-year delay in diagnosis. Every patient ends up going to gastroenterology, they go to rheumatology because they develop autoimmune disorders as all this inflammation goes. They end up on narcotics, they end up going on disability, they end up getting CT scans, MRI, PET scans, ultrasounds, they see a second doctor, a third doctor, a fifth doctor, they have a diagnostic laparoscopy where the endo is hopefully diagnosed, and they go to another doctor who ablates them, and they have 5 or 6 more surgeries. So the waste in the healthcare is ridiculous. If our organizations made this a priority, there's close to 200 million patients worldwide who have endometriosis. Like, enough is enough already. So we've got to figure out at the bottom level, I think from our organizations, how do we make this a priority? And if one thing that I've learned, and I've been telling Shannon over the years, the biggest change in endometriosis has come in the last few years since Shannon Cohn has gotten on the turf, and she has been making a change with that Endo-What with her Endo-What movie, and all the advocates like Endo Warriors and EndoCo, and those are the people who are trying to make a difference. So I think we all have to work together, and we have to change it at the insurance level. Do you think I want to not take insurance? No way. But I can't even pay my malpractice to operate on a patient if I took insurance. So It is so frustrating as a physician. It's so frustrating. It's like beyond words.
Yeah. I mean, and as you can see from Dr. Orbuch when she talks about, I mean, we're talking about large institutional resistance to this type of change. And endometriosis, I've been told more so than other kind of disease landscapes, condition landscapes, that it's so fractured in a lot of ways, politically, within the community, with egos of physicians or, you know, different groups. And I was, you know, when I was filming Endo-What, I've talked to, you know, dozens of experts, and many of them off camera after the, you know, when the camera stopped rolling would say, you know, oh, the change has got to come, you know, we've got to have change. And I'm like, well, how do we get the change? And they all say it has to come from the patients, because the endometriosis community, the professional community, is so fractured, and there's such great institutional resistance that really, like, there's not a lot of push, you know, against the status quo right now. I mean, everybody, you know, most people are doing okay. You know, ACOG's doing okay. Insurance, you know, they're doing okay. Pharma's definitely doing okay. So who's suffering from this status quo? The patients. I mean, Dr. Orbuch just listed all the things that patients have to go through and the tremendous, you know, burden it puts on the healthcare system. Not to mention our lives, how our lives are impacted. We are needlessly, you know, miss out on our career, miss out on, you know, being active in high school and college. Our personal relationships suffer. So many women are rendered infertile needlessly because of this disease, because they have gone years with it destroying their body. And, you know, you can tell this really gets me too, because it's all needless. That's the problem. Because we all, you know, and we are working on this, groups that put patients first, that are patient-led, need to come together, as we have been doing, and we're getting momentum to do that, to demand change. That's the only way all of these changes can trickle down, so that, you know, surgeons like Dr. Orbuch, who are trying to do great surgery and good work, can be compensated so they can have a you know, an active practice, because we need her to be in practice.
Yeah.
So, oh, go ahead.
Sorry, no, the coding issue makes it really difficult for patients to even appeal denials in care. I went through that where I was, you know, submitting information about why excision is superior to ablation, but the fact that there is not even a code to justify I'm saying what I need, it all just falls under the same umbrella. I remember my first rejection letter for my appeal said that my health insurance company, you know, investigated my claim and found that there were X amount of physicians in my area that could do the surgery I requested, and they listed endometriosis ablation. And I'm like, this is, it's pointless, because I'm fighting for something that they don't even know exists, or don't even acknowledge that exists. So then where do you go from there? Honestly, I know that some patients have been successful in applying for gap extensions for out-of-network care. But something a lot of patients probably don't know about either is that, and I found this out the hard, long way in trying to fight my insurance company to cover my excision surgery, is that when you sign up for employee benefited healthcare, there's something called the ERISA Act that basically, when you are covered under your employer, you're signing away your ability to ever sue your health insurance company for any type of negligence or bad faith type of claim. And that's something that I don't think most people know. Hopefully it doesn't always have to come to that point or come to these dire circumstances. I did have to sue my health insurance company to get my surgery covered. And I was lucky enough that I happened to have just taken myself off of my employer plan and signed up for the Covered California, which is the Obamacare version of healthcare. And just for that reason, I was in a place where I could go forward with a lawsuit. If I had been on my employer's insurance at the time of my surgery, I wouldn't have had any case. And that's insane. And most people don't know that. It's some small print, dotted line stuff that you're signing up for that you don't even know that you're signing up for. So.
I actually want to backtrack for a second, because I realize with all of us being very well versed in endometriosis, when we jump into discussing excision versus ablation, if people perhaps are joining us now but missed Endo-What, which does a really great job of explaining the difference, you might not understand what the difference between endometriosis excision versus endometriosis ablation. So Dr. Orbuch, if you want to give like a quick 1 minute, what is the difference between the two surgeries? Go ahead.
Sure. So ablation, the wrong surgery, is a very superficial burning, whereas excision is a complete cutting out or removing of a lesion. So the way that I explain it, you know, like if this, let's say this is my pinky's an endometriosis implant. Ablation is a superficial burning that would maybe take the top 2 millimeters of my fingernail off while the entire lesion still remains. Excision would be literally excising or cutting out the implant in its entirety. And the reason it's so important is because the lesions of endometriosis not only structurally pull organs and cause organs to stick to other organs, but those implants are also inflammatory and setting off whole body-wide inflammation. So the two modalities can't even be in the same paragraph, let alone the same chapter, because you can't equate one with the other. Ablation just does not work, and excision is supported by prospective, randomized, double-blinded, 5-year, well, I guess it's not double-blinded because the surgeon knows what they're doing, prospective, randomized, 5-year data. We have good data to say that excision is far better than ablation.
Now say that 5 times fast, the double-blind, randomized. So now that we've kind of explained that, to go back to the affordability topic, because I don't want to dive into all of that and talking about how it's expensive and then discourage people from seeking out quality care. But if that is a barrier for people who can't afford it, what are some recommendations? And not like, no one here is a financial expert, so we're not talking about, you know, go start saving your money or, you know, invest in the stock market. But what are some ways that you can get care that is perhaps not, you know, excision surgery with your number one choice surgeon, but what are some ways that you can advocate for yourself? And, you know, what is the middle line essentially?
Can I take this one? In Shannon's movie, Mary Lou Balawag says, you need to know your disease more than anyone else. And I think that's so important. You need to research, you need to read, you need to know. But there are endoexcisionists who take insurance, and those typically are the ones at the major medical centers because they're employed by the hospital where they'll have an endometriosis, let's say, division. So they're a salaried employee, but the hospital is getting all the rundown from having the patients in the hospital, meaning because the hospital is getting the radiology, the surgical fees, the medical clearance, and all those things. So those those physicians take all insurances. So you have to look, and there may be a longer waiting list, but there's some really good, I know like University of Pittsburgh has some good in-network doctors, but you just have to really research the doctors. Sometimes people say they do excision and they do a lot more ablation than excision. But there are some who are out there.
And what are some other things in the conversation of caring for yourself if you have endometriosis? What are some other things, whether, you know, before surgery or after surgery, that people can do to care for themselves and their, you know, chronic pain?
I mean, you know, as you probably learned from Endo-What, the people that watched it just then, you know, endometriosis is a very individual disease. So, you know, what may work for one person will not work for the next. So I just have to put that disclaimer first. That said, there are things that people can do to help, you know, manage symptoms. You know, of course, I believe that if you can get to an excision surgeon to get the endometriosis out of your body, then once it's out of your body can start healing, you know, after that, you know, repeated inflammatory cycle that the lesions cause. And there are things you can do to calm it down. I think nutrition is really important, following an anti-inflammatory diet. And again, like with food, you know, what works for me may really bother someone else. You really have to work at it. It's not a disease that you can say, okay, I'm going to eat this, this, and this, and everything's going to be great and it's going to work for everyone. That's just not the case. And I've, you know, done things like acupuncture at certain times when I have, you know, acute kind of flare-ups, yoga, meditation, things like that, which I know that when someone's in severe pain, when someone says that, you're just like, oh my gosh, stop talking. I'm in severe pain. I don't want to talk about meditation. How can I meditate? Because I can't even concentrate past the pain. I understand that. But it all has to work together. And I'm definitely suspect of a lot of the medications that are out there. But at the same time, I've used certain medications to help manage symptoms with the caveat that I know that I need excision surgery. But, for example, right now I have an IUD that helps me really it works for me after I've had excision surgery. And it's helped, so that's an instance where, Western, medical device has helped my symptoms. So I'm not going to say categorically they're all bad, but at the same time, you really need to know what you're putting in your body. And you need to understand that whatever information is being given to you about that product or that drug or that food or that supplement or anything, you need to understand who's telling you that information and do they have something to gain or profit from it. And if they do, then maybe dig a little bit deeper and understand, is this really the best thing for me? And the great thing about, the 21st century is there are a lot of really great groups online that, there are a lot of women and people that have been there before you that can also give you advice. So yeah, that's what I have to say about that. Jenneh, what do you think?
Yeah, I definitely found that when I combined an East meets West approach to my care, I saw the most benefit. So of course I started with excision, but also supplemented with diet modifications, anti-inflammatory diet, acupuncture, pelvic floor physical therapy was a game changer for me. Having so many pain points, and especially having diaphragm disease, it was muscular dysfunction from head to toe. So I'm still in physical therapy and I'm 4 years post-excision and I go twice a month still, religiously to keep everything working the way that it should. I still have scar tissue from all the surgeries. And so I think realizing that surgery is not the only part of this puzzle, it's a huge part, but like Shannon said, diet and mindfulness. And I know that that's a tough one to sell for some people, but our minds are so powerful in what our body experiences, and having those two things connected and grounded and speaking to each other kindly is really important in our healing. So.
Mm-hmm. Great. So we talked a little bit about improving access to care in terms of, affordability. And I want to talk about some other barriers to care. And one of them is that endometriosis is often discussed in very gendered terms. So while the disease predominantly affects cisgendered women, trans men, non-binary or gender non-conforming folks, and even cisgendered men can get diagnosed with endometriosis as well. What are some things that we can do to make the endometriosis community a more welcoming space for everyone, regardless of gender?
Wow. I mean, that's a great question. And that's something that, I think we're all working on and trying to be inclusive, like first starting with language and an awareness of all of the groups that it affects. And understanding that, we have to be, I have to, be sensitive and understand and being open to learning about how it affects different groups and how we can do better to be more inclusive. It's always difficult when you're talking about a disease that, of course, historically predominantly affects women, and are, people born with women, female reproductive organs, to then open up the conversation. But I am encouraged that that conversation is starting, and we're opening it up in a way to be more inclusive. I'm curious, Dr. Orbuch, how does it affect you from the medical provider perspective?
I think I love the conversation with my patients, and I love listening to my patients, and I honestly treat everybody the same, no matter. It doesn't affect any care that I'm giving or not giving, because I treat every individual the same. Obviously, there's just more patients who I know just over the years who are identify more so just as a woman than not. But I imagine, I love that the conversation's changing. I love that the awareness is changing, and I love that the recognition that we need to be better is out there. But I treat all my patients the same. I just try and make them better and try to make their lives, allow them to live their lives to the fullest.
Yeah, I think language is important, and I think it might even need to be a bigger conversation amongst providers and advocacy groups and everyone kind of in this space that's pushing for the same thing, where we do have this paradox of our statistics are based off of cisgendered women. And so how do we use inclusive language without diluting what we know is statistically accurate? Because we have to put out accurate information, and all that we have right now for that is on cisgendered women. So how do we keep that in mind when we're sharing statistical relevant information while also trying to be inclusive of another population of people? And I haven't quite figured out how to perfect that yet. And so I don't know, maybe that might be something that we need to kind of all sit down and have a conversation about how do we do that well so that everybody feels included in the conversation.
Definitely. I think there's a lot of challenges too when you're talking about a disease that, you know, Jen, I know you mentioned this a lot because you have thoracic endometriosis, and that's not typically how people think of endometriosis, because we think of it as a disease that affects the uterus and the ovaries. And then when we talk about those organs, we often think of them in very gendered terms. And so it is definitely a challenge in the community of how we talk about a disease that is typically very gendered in a way that is inclusive. So kind of continuing this discussion around inclusive, another barrier to care is it can be hard to get an endometriosis diagnosis if you are Black or a person of color. Whereas white women get diagnosed with endometriosis, Black women tend to be underdiagnosed or instead told they have conditions like pelvic inflammatory disease, or doctors don't believe their pain. How can we fight diagnostic racism and create more equity in the community?
I think being aware of cultural biases. I think as practitioners, I'm one myself, so obviously I'm aware of it, being an African-American woman and a nurse, that we have biases that are internal that we may not know that we have, and it does affect how we care for patients. And I think practicing culturally competent care, and part of that is acknowledging that we have internal biases. We can't take care of people of other cultures well if we don't acknowledge that we don't know as much as we can know about different cultures, specifically if you're working with a very diverse population of people. I'm not going to approach the way that I care for a Latino American person the same way that I would an African American person, that I would a Caucasian American person. And knowing that we need to tailor our care based on the patient that's in front of us, I think is so important, specifically for African American women and when it comes to pain, because it has been dismissed and it has been downplayed, and there are so many ridiculous, bogus statistics about how we experience pain. And if that's what you're taught going into medicine, then that's going to play out as a bias in how you care for this woman. So I guess long story short is check your bias as a practitioner, because we have to.
If as a patient, if you feel that your doctor, and this could be any sort of biases, whether that's around gender or race or, even age for younger patients who are teens, and their doctor says, you can't have endometriosis because you're 16. Is it worth trying to have a conversation with your doctor? Is that a sign that you should get a second opinion? How do you navigate those scenarios when you feel like your doctor isn't providing either culturally competent care or age competent care or listening to your concerns?
Well, I think if someone isn't aware they're doing something, there's no opportunity to fix it. That doesn't mean you need to stay with them if you don't feel comfortable. But if every person that is experiencing care that is not culturally competent is just moving on without having any type of conversation, whether it's an email or, filling out a survey, whatever it is, I think that needs to be relayed, because this person may not even know that they're doing it. So that's really important. And I think for a patient, it's feeling like it's their right to speak up, to say something. Like the other day I had a doctor's appointment where my doctor kept pronouncing my name wrong. And that's something that I used to just let slide. And it sounds like a really small thing, but I used to just let them call me the wrong name throughout the entire appointment. And yesterday I was like, you know what, this is so silly. And in the middle of the appointment, I said, you know, actually my name's pronounced Jenneh, not Jenneh. And it was awkward. I will not say that it wasn't. She felt terrible, but it was like, I'm not doing her any good by thinking she's calling me the right name every time she sees me when I have an opportunity to change this. And so I think just feeling like we can speak up when something is happening is really important.
Definitely. And, you know, talking about advocating for yourself, what are some other ways that patients can advocate for themselves?
Oh, wow. There are a lot of different ways. I mean, for at first, just becoming informed about their condition, in this instance, endometriosis, and trying to seek out unbiased, fact-based sources of information, and using that to inform those around them. That's one reason we made Endo-What, is to use it as a catalyzing tool for education and for change, because we recognize that basically Endo-What was meant to be, or is meant to be, everything I wish I had known when I first had symptoms at 16. I mean, of course, not everything, but a really good starting point, to understand, okay, this is what I need to know now to go get individualized care for myself. And I don't need to waste thousands of dollars on, needless medical, exams, tests, procedures. And I don't need to go see all of those doctors. And I don't need to suffer for a decade. So finding those sources of information that can help empower you to then go and make choices for yourself, finding others that have, are in the same position so that you have support, and that so we can all work together to change and to advocate. Like Dr. Orbuch said earlier, like, this is a disease that if there's going to be change, which I think we all recognize, there needs to be a lot of change. It's going to come from the patients. And we touch on that a little bit at the end of Endo-What. And I will share that we have a new film coming out soon. It's been a bit delayed because of COVID. So we're, nailing down the date, now. And it approaches endometriosis as a social justice issue, and looks at all of the things that we are talking about in this conversation and beyond that. And the idea is that then it can open up these larger conversations and put even more pressure on the power brokers and the institutions that really are the gatekeepers to better care. So we're excited about that. And, individually, we can wield a lot of power, in our own lives, but collectively, that's when we can really start to see large seismic shifts. And I'm excited about that.
Mm-hmm. Yeah. Definitely an exciting time. All right, so we have about 15 minutes remaining, so I want to open up to audience questions. We have a few, but if you have any questions, please feel free to submit them, and we'll try and ask as many as we can. The first question is, how can allies, whether that's friends or family, best support people with endometriosis?
I think doing the same amount of work of informing themselves about the disease and learning it, what's true and what's not, and helping to dispel myths. I think that having someone that is just as engaged in the process of figuring out from, diagnosis to advocacy can only happen if that person understands what it is that you're dealing with. And so whether it's just showing them Endo-What, which is what I did with my family. It was the easiest way to explain to them what was going on. It was a one-stop shop. I just sent it all to everybody and they all got it. So thank you, Shannon, for that movie. But 100% is being informed is I think really integral in being a good ally.
Mm-hmm. Anything else you would add, Shannon or Dr. Orbuch?
I would say, just encouraging them to listen, because so many women with, or people with endometriosis, definitely, a lot of the pain or the symptoms they have are chronic. So I know, my own personal relationships were strained with my parents first, or my grandparents, then with boyfriends, then with, my own husband, because it's hard, when they aren't necessarily experiencing the same physical symptoms, and their partner or their daughter or their friend, has to cancel, or, has to, or tries to grin and bear it, which is what I tried to do a lot, but they know, and they feel like you're holding back. So there's this kind of, there's a miscommunication there. It's very isolating, the pain. And we get into that in Endo-What a little bit, because it's so true. So trying to have those conversations, and being patient and listening. And my husband is a filmmaker too, actually, and he was involved in a lot of the filming of the interviews in Endo-What, and it was very interesting for him to interview so many different women, and he kept hearing the same thing over and over again, a lot of threads that a lot of the women said, and he actually apologized to me after he heard, and he's just like, I thought I understood, I thought I was a good ally for you, and I realized that I had no idea. So that was very, eye-opening for both of us. And I had a lot of people say, thank you for making Endo-What, it saved my marriage. Or, my parents finally understand, and we can find better care. So I've been really heartened to know that not only has it helped empower or educate patients, but it's really helped kind of heal or bridge some of the divisions that having a chronic condition like endo has caused.
At the end of every consultation, when I'm educating my patients about endometriosis, I always give them good resources to learn about endometriosis. And one of them is the Endo-What documentary. And invariably, when they come back for their subsequent visit, the family member says, thank you so much. My daughter and I, my wife and I have such a better relationship. I now understand them, and it's so validating. And the same thing I do on any visit where a patient comes along, whether it's a friend, a boyfriend, a girlfriend, a partner, I compliment that person who comes to the office with them, because it is so important to have someone who wants to listen and wants to learn. And I mean it from the bottom of my heart when I say to them, like, I'm so happy. They always say, do you mind if my significant other, whomever joins me, and I let them know, no, it is so wonderful that they are here supporting you. And I talk to them and help them understand and encourage, and I try and make it like a team. And those patients tend to honestly really do the best because they have the support. And then if I'm talking about this anti-inflammatory diet, the partner's like, let's do it together. And what a better way to succeed if you have a partner to do things with, or why don't it's validation. And I think a lot of the validation comes from Endo-What. Thank you, Shannon.
Yes, if you didn't catch Endo-What before this, definitely make sure you watch it after this. So we have a few more questions. These are a bit more medical. So Dr. Orbuch, probably for you, if someone has excision surgery, would you recommend further excision surgeries if the person believes that endometriosis was left behind, or they're still having symptoms?
So first of all, I need to listen to that patient's description of their pain. What symptoms are they having? Because what's so important, and Jenneh and Shannon touched on it, there's all these coexisting things that go on when one has an inflammatory disease for 10 years or 20 years before it's recognized. And, one of the big ones is pelvic floor tight muscles, which plus there's a bunch of other things that coexist as well. So I need to really tease out and take a really good history to try and figure out what is causing that patient's symptoms. The second is, a lot of doctors say they do excision, but they didn't do excision. It happened to me today in the office, I think 1 or 2 of my patients today, where they finally obtained their operative reports, and they said, no, my doctor said they excised my endo. But on exam, I knew that I was suspect that that was truly the case. So then they return, and in this instance, and pretty much every instance, I literally read the procedure, full duration of endometriosis. And then I read them the lines in the operative report. I'll never say anything bad about a doctor because that's just not who I am. I literally just read it to them. So the second question is, did they truly have excision? And the only way to know is to really read the operative report. And I encourage all patients out there, whenever you've had a surgery or an ultrasound or an MRI or a test, before you walk out of the office, get a copy of your medical records. And after a surgery, get your operative report and so on. So if it is true, there are times where even when I'm operating, I may leave endometriosis behind, but for a particular reason. Let's say I've excised 95% of it, but that last 5% is I feel that the risk is outweighing the benefit, because someone wants future fertility, or I thought maybe I would jeopardize that. So sometimes there are reasons why we leave things behind. But I think more often than not, it's the lack of skill and the ability to remove all the endometriosis. So I think it's appropriate to do another surgery, but first confirm that there isn't any coexisting conditions. And I talk a lot about that in my book that I wrote last year, Beating Endo, How to Reclaim Your Life from Endometriosis. I don't even talk about excision of endometriosis till one of the last chapters in the book, because I think it's so important to treat the whole body from an East meets West perspective. So first, make sure that you don't have pelvic floor tight muscles or bladder hypersensitivity or like a bacterial overgrowth, also kind of known as a leaky gut, a flared central nervous system known as central sensitization. Hernias, we need to look for all of these other things. And then we need to evaluate the surgery was done. And then if you're going to need another surgery, make sure you really do research on that, doc.
Great. Another one of the questions we have is asking about the difference between polycystic ovarian syndrome and endometriosis. And do you often see overlap between the two, or is endometriosis often misdiagnosed as PCOS? What's that sort of relationship?
It's so interesting because they don't belong together at all. So PCOS does not cause pain. Endometriosis causes pain. I don't know why I get so many patients who come into my office and they're told, I've had debilitating pain my every period or all month long, and my doctor told me I have PCOS. That would be like, I don't know, saying the sky is orange. I mean, it's not even a thing. So polycystic ovarian syndrome is when your menstrual cycle is irregular. You tend to have like oily skin, facial hair, nipple hair, and elevated testosterone levels. And perhaps on ultrasound, you may have this special feature called a ring of pearl sign on imaging. But nowhere, PCOS does not mean you have pain. Pain is not even in anything related to PCOS. So PCOS is kind of common, about 10-ish, 12%. Endo is probably about 10 or 12% of the population. So I think it's probably two common things that are occurring. So maybe some patients have both, and maybe that's how it's lumped together. That's the only thing I could think of, but they couldn't be two more separate entities.
Right. And here's the next question, also medical, but also I know this one has a lot of room for debate. How common is it for endometriosis to grow back?
So the big thing that I always tell patients, where you're excising the implant, it's very unlikely that the endo will come back. What happens is when a patient undergoes ablation surgery, and then they present back to their physician 2 months later, 4 months later, 6 months later, their doctor says, oh, it must have grown back. Let's operate again. It's like this rabbit wheel or hamster wheel of like endless, never-ending surgeries. I think my reoperation rate's probably less than 5% of patients. Okay. And you have to know what it looks like, number one. And like we had talked about, so many of the lesions aren't what's typically taught in residency and medical school. So the first surgery, if it's done by a non-specialist, those lesions are missed. So it's not that it's growing back, those lesions were missed in the first place. Or secondly, the implants are fulgurated or cauterized or burnt as opposed to ablated. So they were never removed in the first place. So I think that it's like a big myth that it comes back, like the way that most physicians will say. There's no reason why physicians should put patients through surgery after surgery every 6 months to a year. I think it's criminal, quite honest.
And a lot of times, isn't it, and Dr. Orbuch could speak to this, it's a lot of other pain generators that are non-surgical causing continued symptoms, correct?
That's exactly right. And I've really changed my approach in caring for patients over the last probably 7, 8, 9 years. Whereas I came out of a surgical fellowship and I loved to operate, and we would jump in and we would just operate. But then I recognized that there were all these similar descriptors that patients were utilizing because I love to listen to patients. One of my mentors, Harry Rich, taught me to listen. And my dad's a doctor, and I remember going on rounds with him. He's a cardiologist. And I remember how he listened to his patients. And that's what I do when a patient comes into my office, is I listen to how the words that they're describing is their pain. So burning pain is typically nerve. They have flared central nervous system, or the muscles are squeezing the nerves. Like adenomyosis has like a pressure, a heaviness. Muscles is like a gripping, a squeezing. So there's different descriptors. So and we have to, even in my fellowship, I didn't learn about hernias and bladder hypersensitivity or painful bladder syndrome or interstitial cystitis or whatever you want to call that. I didn't learn about small intestinal bacterial overgrowth. I didn't learn that anxiety and depression worsens pain. I didn't learn about the food that you put in your body flares the inflammatory condition about endometriosis. So these are things that, just because my practice is solely devoted to endometriosis, I picked up on these intricacies, and that's why I wrote the book. I don't jump to operate on my patients as much as I love to operate. I try and down-regulate their pain. One of their first stops, if you ask any of my patients, it's probably sending them to pelvic floor PT if you've been my patient in the last probably 10 years. And that's why when I wrote my book, I asked a fellow pelvic floor physical therapist, Amy Stein, I'm going to write this book, but let's write it together because it's going to be a better book for patients out there, because the tight muscles can be as painful, if not more, than the endometriosis. The bacterial overgrowth that develops from the years of inflammation and the 10-year or more delay in diagnosis can cause tons of the bloating or the constipation or the diarrhea. And the bladder hypersensitivity, the central nervous system hypersensitivity can cause worsening symptoms for all of the coexisting conditions. So we always have to evaluate for all of them. That's something that I'm so passionate about.
I feel like you kind of answered this in that description, but I do want to try and squeeze in one last question before we finish for today. And that's, if your symptoms aren't debilitating, is surgery, excision surgery in particular, really the only option?
So I never push patients to surgery, but I think it's really important to understand about endometriosis and understand that it's an inflammatory condition. And I like to educate and empower patients. So I love nothing more than when I get a 12-year-old in my office, or a 17-year-old or a 19-year-old, or maybe someone's not quite ready to have surgery, but I educate them. And I have tons of college students, and if they say to me, my dream, like in your movie, is to have a white picket fence, and they say, I want 4 kids and fertility is so important, I say, let's do an evaluation of your fertility. I send them to specialists who understand how to test for ovarian reserve and who understand endometriosis's impact on fertility. And I cannot tell you how many college-age students, I don't want to freak anyone out, who have endometriosis have very low ovarian reserves. And I actually had one of them who came in for a follow-up this morning, who I operated on 2 years ago, and then she froze her eggs. And she is so grateful that when she was in college, I said to her, let's just check it, because I know you told me this is something that's very important to you. And she went ahead and she froze her eggs. I feel that knowledge is power. So I think one should know, and I think it's important to not delay childbearing. We don't want to have a kid when we're not ready to have one. We don't want to have a kid if we don't want to have one. But if someone's thinking, I'm going to wait until I'm 40 to have a child, I think they need to understand that even someone without endometriosis being 40 and attempting fertility could be difficult. So I think more education. No, you don't need to jump in and have a surgery if your symptoms aren't debilitating, but you can live a better life. And often patients don't realize how debilitating they are until they start to feel better, until they get into pelvic floor PT, and then they recognize, wow, I didn't realize how much that was affecting me, or until they fix their gut issues. And then I think a lot of people think it's normal to not have a bowel movement for 4 days. That is not normal, or 3 days or 2 days. So an education of what is normal, and an education about a whole life down regulating and decreasing inflammation, I think is so valuable and important.
Before we close out for the evening, Jenneh and Shannon, any last pearls of wisdom you'd give to our listeners?
Yeah, I would say trust your gut. You live in your body and know it better than anybody else can and ever will. So if you feel like something's wrong, likely something is. And to, explore all of your options. That one doctor's opinion is not judge and jury. Get multiple opinions if you feel like that's what you need to do. And empower yourself with education, because you can't make empowered decisions if you don't have accurate info that you're going off of.
Mm-hmm. I just kind of underline, italicize, and bold whatever Jenneh just said. Mm-hmm. And also just to emphasize that you're not alone. This is a condition that can be very isolating, and whatever symptoms or journey you may have, whether it's with pain or infertility and feeling like you're the only one that feels this way and no one understands. And please understand that you're definitely not alone. It can get better. There is a community out there for you, of people that understand exactly what you're going through, and you can find them. So I would just encourage you to get online if you're feeling that way, and you'll find your people for sure. They're out there. There are a lot of us, 200 million worldwide. We're out there.
Definitely. Thank you so much, everyone. And I want to thank, we want to thank our special guests and our audience for participating in this call to action conversation. For a recap of the organizations you can support around this topic, visit day 2 on the rePRO website. And please make plans to support rePRO Film Festival by purchasing film tickets and attending more of the call to action conversations. You can get full info at repromamafilm.org. Thanks, everyone. Have a good night.